GP in Surrey. Good afternoon, everybody. Can you hear me okay? Okay. If I go quiet, put your hand up. Those are my declaration of interests. Hopefully, at the end of my talk, you'll appreciate a bit more how to limit the use and duration of antipsychotic treatment, when antipsychotics may be necessary, and unfortunately that is the case in a few cases, and how to initiate and stop antipsychotics. And I know Nick hinted at some of that in his previous presentation, if you were here. So we had an audit which showed excessive use of antipsychotics, and we've had a more recent audit that's shown that this has decreased to about 16%. And most people consider that that is a realistic percentage that, unfortunately, we might need to help some of our patients with dementia. And that if we're looking at the reasons why this medication may be necessary, we can look at the symptoms: agitation, psychotic symptoms, aggression and distress, and that we can look at patient characteristics: younger age, people who are in care homes or inpatient settings, acute trust hospitals, people with vascular disease or Parkinson's disease dementia, a greater severity of dementia. So perhaps when you're looking at your patients, you might think, about their risk, and maybe talk to the staff in the care homes, the residential homes, about specific management techniques, non-pharmacological, that you can use to decrease stress and anxiety. Basically, the results of the audit showed that there were areas of relatively good current practice, much improved from previous, that there was much better consideration of alternatives to antipsychotics, and that we were getting better at documenting the target symptoms. And this is something that particularly secondary care do if your person's referred to them. They do it on what's called their RIO system in our area, whatever IT system they're using this month. But there are areas for improvement, and in particular about the review once a person is given an antipsychotic medication, and the strategies to decrease the use overall. Again, you should look perhaps more closely at the patient characteristics. So I'd encourage you to audit and have a look in your practices, and what should you audit? Well, these are the most frequently prescribed drugs, the typicals or neuroleptics, and the atypicals or second generation. I do suggest you take chlorperazine out of your audit, Stemetil. So please exclude that one, otherwise you might get a higher use than you anticipate. I'd also encourage you to look at the dementia diagnoses. And often it's a history of instead of an actual diagnosis. And that won't come up on your dementia register. Nick was also talking about looking at your patients in your care homes and even in the community settings to make sure that you've got a proper recode there. And there's, in the London antipsychotic audit tool that I helped develop with colleagues there, there is a list of recodes that you can use, a choice of about 5 or 6, or if you want to go more detailed. Please be careful with patients who have had a history of serious mental illness. That's bipolar disorder or schizophrenia. They often have vascular risk factors, have had metabolic syndrome, they're at risk of dementia. They're on antipsychotics often for another reason, because of their psychosis. And if you stop those antipsychotics, you're at risk of emergent psychotic illness. So please look at the whole history, the whole patient. Also, when you're auditing, consider the duration of treatment. If a person is on an antipsychotic, you inherit them. Sometimes I do when they come from another area into a nursing home I look after. If the behavior is settled, then consider the down titration, and I'll talk about that in a few slides. I'd also encourage, when you audit, to think about more than just antipsychotics. We don't want to substitute hypnotics and benzodiazepines, so it's another 2 groups of drugs to consider. We want to consider also the appropriate use of medications that are approved for the management of dementia. These are for Alzheimer's dementia, Lewy body dementia, and Parkinson's disease dementia. So you could audit the appropriate use and the inappropriate use of antipsychotics and other drugs that may be substituted. A lot of people equate agitation and aggression alone with behavioural and psychological symptoms of dementia. That's what I've got BPSD up here. But there's a whole range of symptoms that constitute the BPSD. And I'd encourage you also to consider the management of these symptoms because they can often be challenging and problematic to you. And they're often, some of them are easier to manage, others like apathy we have great problems with. The neuropsychiatric symptoms can often arise out of frustration or the environment, as Nick said previously, but they also have an identifiable neurobiology, so an organic reason. And people who have associated vascular features, they'll often have deposits called white matter lesions in the brain. And the areas that those deposits occur in are, you get disruption of the pathways, and that leads to symptoms of BPSD that correlate with where those lesions are. You also have an interaction with environmental influences. It can be as simple as a colour they don't like in the bedroom, or the windows not open. And you have personal psychological predispositions. They may have had anxiety all their life, and dementia often just really makes that worse. You may have a physical problem. And if you've ever tried to communicate with somebody that you've gone deaf in your ear, you've got toothache and you can't speak, and you're not quite sure how to indicate, and you get frustrated because they won't listen and you're in discomfort, you can perhaps appreciate why a person with dementia might get frustrated if they can't get their point across. The BPSD vary across the severity. So here we have a mini mental state score. This is mild, moderate, and severe. And the colours across the bottom show you across the spectrum of severity